Good morning. This is Dr. Joe Moscato of the Missouri Cancer Associates speaking this morning on stem cell transplantation, something that is becoming more common and commonly used on our patients from 2100. Now, stem cell transplantation refers to the process of intense chemotherapy with rescue of the bone marrow with stem cells. One can use autologous stem cell transplantation, where the stem cells actually come from the patient, are harvested and frozen. And this is most commonly used for lymphomas that have relapsed, and allogeneic stem cell transplants, where they come from another donor. Cord blood can also be used, so the source of stem cells can be cord blood, peripheral blood, or bone marrow. Now, there's another kind of transplantation called a mini transplant, a reduced intensity stem cell transplant, which are used for older patients in some diseases. And the major goal there is to create a graft versus tumor effect to try to treat the cancer more than just chemotherapy. You'll hear the term MUD, which refers to matched unrelated donor. And HLA typing is used to match donor to patient, and often matching 10 antigens. So you hear the term 10 antigen match, for instance. The indications for stem cell transplant in almost all situations are reserved for relapsed disease, and there are studies of early allotransplant in high-risk AML because, especially with high-risk cytogenetics, for example. So you might hear us discuss that as first-line therapy. An autologous stem cell transplant is used for, it can be used for a variety of things, but most commonly multiple myeloma, in which we do use it first line after induction, and non-Hodgkin's lymphoma, especially large cell, in second remission. Hodgkin's disease also in relapse, AML occasionally, and the other scattering are used on occasion. Allogeneic stem cell transplant is used for the diseases noted, especially leukemias, some lymphomas, CML, especially on progression after drugs like Gleevec, and the non-malignant diseases on the right, in which they potentially can cure the bone marrow diseases noted. Now, early complications are mucositis, acute graft versus host disease, veno-occlusive disease of the liver associated with ascites and high bilirubins, and often death, infections, bacterial and fungal early, and viral infections, especially CMV late or later. And one can also see transplant-related lung injury as a complication. Acute graft versus host disease, which you rarely will see but can come from transfusion of blood which is not radiated, can be seen as a skin rash early, macular papular, burning, may become bullous and necrotic, liver toxicity, which must be distinguished from drug toxicity, viral infections, and VOD. It may require a transjugular liver biopsy, and the GI tract, where diarrhea is most prominent, but distension, nausea, and vomiting, and a rectal biopsy is sometimes necessary to distinguish it from infection. Occasionally, graft versus host disease affects the hematopoietic system, kidneys involved. Hyperacute GVHDs in the first 14 days is rare and can lead to fulminant multi-organ failure. And the transplant physicians use a variety of techniques to prevent GVHD, various drugs, and you may hear of cyclosporin, methotrexate, Prograf, Cellcept, and others. Chronic GVHD, which is one we're going to see more often because these occur later when our patients may be back in our care, are associated with older age, a higher degree of HLA mismatch, a history of acute GVHD, unrelated donor Buffy-coat infusions, which may be necessary, and CMV positivity are all of these are risk factors. Chronic GVHD is more like a severe autoimmune disease. The skin can be thickened and non-pliable, scleroderma-like, and can start as an erythema with plaque-like changes, and ultimately stiff and scarred. The liver can be attacked, especially in bile ducts. One can have an elevated bilirubin and ALK phos, and the GI tract can lead to dry lichenoid changes, scarring, strictures, ulcer, and weight loss. The lung can be complicated with bronchiolitis obliterans, cough, respiratory failure, and also one can see vaginal dryness, Sicca syndrome, autoantibodies. Chronic GVHD is graded as limited, which is skin or minimal liver involvement, or extensive, which is extensive liver and skin involvement, or skin or liver plus other organs. The treatment is highly specialized and not something that we would design, but it's usually a combination of steroids and immunosuppressive drugs such as cyclosporine, thalidomide, tacrolimus, Cellcept, Puva, Rituxan, and others, although it can be very difficult to manage. The survival from autostem cells, which mostly is from myeloma, can be quite good initially, but the long-term survival may only be 15%. The best results are seen with relapsed Hodgkin's disease and non-Hodgkin's lymphoma, especially large cells, where the cure rates may be as high as 35 to 40%. Low-grade lymphomas have benefited sometimes from autostem cells, but again, these are very difficult diseases to cure in the long run, as you know from our previous talks. And occasionally they've been used in AML and ALL. Those diseases are usually treated with allogeneic stem cell transplant. The survival from allo stem cell transplant is very much dependent upon the match and the age. The early mortality may be 10% in CML in young patients, or 50% in older patients receiving a MUD. There is less treatment-related mortality with reduced intensity transplant, but the cure rates may be correspondingly lower. For AML in second remission, long-term survival of 20 to 55% can be seen, depending upon the study, the age of the patient, and so on. So in summary, the toxicity with allostem cell is high, but is used for young patients with no other chance for cure. Autostem cell transplant is much less toxic, with fewer indications, and the best indications are multiple myeloma and relapsed lymphomas, germ cell tumors, and neuroblastoma. Be aware of severe immunosuppression in these patients. Look for organ damage, and it requires close communication with the transplant center. So I appreciate your attention this morning, and as usual, if you have any questions, please don't hesitate to stop one of us and ask. Thank you very much.